Hi, everyone. My name is Dr. Narjus Flores. I'm a thoracic medical oncologist and also the Associate Director for the Cancer Care Equity Program at Dana-Farber Cancer Institute. You are here to hear the first Spanglish presentation about how bias or how suposiciones affect the care of our patients of the LGBTQ community o comunidades de sexo que son minorías. I'm also an assistant professor of medicine at Harvard Medical School and an associate editor at JAMA Oncology. I normally do not sound like this, but I'm currently experiencing some kind of viral infection and some oral problems, but I'm here with you, trust me. These are my relationships with industry. And I mentioned this because we need to be clear. I do consulting for several companies and speaking engagements for others. How access to healthcare varies from person to person. For some people, it may be a straight line to healthcare. For other ones, may have a few turns. But for others, it can be a very convoluted way to get to healthcare, and thus are all members of the LGBTQ community. This refers to members that have a different sexual orientation but is traditional. They may not self-identify with a binary gender, asexual, lesbian, bisexual, transsexual, people, partners, colleagues, patients, neighbors. So this is what we're going to be referring to today when I mentioned the LGBTQ community or the SOGI community, which is sexual orientation and gender identity minorities. So for this community, they tend to have this very convoluted way to get to access to care. They have delays in diagnosis, they have discrimination, they feel isolation, and they die sooner compared to heterosexual cis males. So how do you see the sexual orientation and gender will affect how you care for patients? Do you see it as something that is a patient's decision or is a patient's choice? Do you feel that love is free and gender is fluid? If that's the case, you are with me, and I need you to recruit you to the army so we can fight for the bias that is affecting these patients when it comes to cancer care. Members of the LGBTQ community have delays in care, as I mentioned, and it's our responsibility and our duty to assure that these patients get adequate care on time and bias-free. It's no longer taboo and should not be taboo or patients' sexual orientation or patients' gender identity. It is important that we communicate with them, we ask with them, and if they feel comfortable, we share that information because we need to know certain aspects of their biologic sex to provide adequate cancer screening. One example of that is our transsexual men that may have a female biologic sex. So we need to make sure that regardless of the surgeries, they get mammograms, cervical cancer screening. So having a good communication and understanding that sexual orientation and gender is an aspect of somebody's identity, we allow that we provide the adequate care. The problem is that culture tends to affect a lot how we see members of these minorities. Is affected by religion, is affected by social norms, and is affected by the standards or the laws in certain countries or states. In the last few months, we have seen more and more regress in some of the support for these communities that really need us. Some state changes have affected members of the LGBT community. In some countries, it's still illegal to have a different sexual orientation. So despite we're extremely proud to celebrate Pride Month with our colleagues and our ally as a cis woman, but we cannot forget the discrimination and oppression that these patients, colleagues, and neighbors suffer across the globe. still happens. So social norms tends to affect a lot how patients of the LGBT community get cancer care. Because doctors, and I'm bringing the blame on us because that's what we're talking about, the bias, the unconscious bias that doctors, nurses, and other healthcare providers have against members of the LGBT community that affects their cancer care. So those are social norms and the mutual expectations that we have as a society come out with. And when somebody may come out of that standard, is seen as different, is seen as weird. And because of that, they're often isolated, they are discriminated, and that affects their health physically and mentally. I love using the gingerbread person to explain how gender and sexual orientation and many other aspects come together. So let's imagine a gingerbread, right? So the gingerbread has first the identidad de género or the gender identity. Do they identify from one gender versus the other, male versus female, or something in between, or none of them, like non-binary? This is related to our brain and also can be show of how we dress, how we behave. Identity, gender identity, o identidad de género. Orientación sexual is different. This is what you are attracted to. Are you attracted to people of your opposite sex? Are you attracted with the same sex? Are you attracted to both, or are you attracted to none, which is also okay because it's asexuality. Also, your biologic sex. Were you born a man or were you born a woman, right? And we have patients and friends that may have biologically a mix between those, like patients with Klinefelter syndrome, and we should have an extra chromosome overlap. So I love the gingerbread to explain. A lot of discrimination is faced by patients because we are not using their pronouns. And we need to move away from saying preferred pronouns and use pronouns because it's not preferred, it's their pronouns. And that ensures that our patients that are already in a very high stress situation, like getting cancer care, feel like they're welcome and that they're understood. So we need to be very mindful of their pronouns. So what are the effects of the physicians and healthcare providers when it comes to the care or the cancer care of members of the LGBT community? First, we receive 0 to none training. The doctors currently are getting more training in sex affirming surgery, hormonal replacement, about risk unique to this population. But for the older generation, including myself, we have 0 to very little training. And when doctors don't have to get training, they don't get enough training, they go and become biased and develop prejudgments against the populations. We saw the worst of the bias against the LGBT community during the AIDS epidemic. And now we continue to see it. We see that these patients are often associated with behaviors that are not true. It is my honor to take care of these patients because as a racial minority, we kind of come together as the discriminated groups. But the lack of knowledge from many healthcare providers provides delays on diagnosis, provides that patients are not addressed with the adequate pronouns, do not receive the appropriate screening. I have seen firsthand how the lack of understanding affects patients' care. Cancer in the LGBT community is a big issue. So tobacco and e-cigarettes is higher in members of the LGBT community. And this is associated with secondary cancers. But unfortunately, these patients are not offered the opportunity as equally as the cis group or the majority group to get lung cancer screening. Further, 60% of oncologists in this survey reported that they didn't have enough information on how to treat members of the LGBT community. And 80% of oncologists in this survey feel like they don't know enough to treat trans people. So when we talk about it, that the doctors don't have knowledge, the lack of knowledge then comes and feeds on unconscious bias. Unconscious bias are assumptions that we made about certain populations based on lack of accurate knowledge, but based on some of the indirect information that we get. So 80% of oncologists currently do not feel they know enough to treat trans people with cancer. And that is a big issue because the needs are different. These patients want and should remain in hormonal replacement therapy during their cancer, depending on the type of the cancer, but a majority of the cancers should be okay. We should continue to reinforce that all staff address patients the preferred way, and also that we understand their additional needs. Some of them may be in treatments that may interact or affect the side effects of chemo. No importa, it doesn't matter the size, the shape, the sexual orientation, or the gender identity. Breast cancer screening needs to be essential for all patients, regardless of the sexual orientation or gender identity. But unfortunately, gender and sexual minorities are not offered the same amount of opportunities to get breast cancer screening. And that leads to higher rates of mortality. So one of the things that we need to take into account is that there's a lot of stigma when it comes to caring for members of sexual or gender minorities. There's stigma because it has been attached to social norms and religion. But we need to remove the belief that it's a choice. It is an identification, it's how they are wired, and we need to respect that. We also need to understand and ask how they like to receive care and how they like to receive information, and which members of their family want to be present. I have seen how unconscious bias of providers, they call their mother instead of calling the patient directly. And that affects the trust that you have with your oncologist. For a woman of color who was also a member of the LGBTQ community, it tends to be a big issue because there's an aspect called intersectionality. So intersectionality is when two discriminated and isolated identities intersect. So a lesbian Black woman has the intersection of the identities of being a minority when it comes to sexual orientation, an ethnic and racial minority, and then being a woman. So all those identities intersect negatively and will worsen their disparities, their cancer health disparities. These are some of the words that Black women, particularly Black femmes, will describe when they have to seek medical care. Rude, some of them are fat phobic, unempathetic, uninterested, disregarded. I can tell you that how many times I have heard how this intersection on identities negatively affect our patients. So we shouldn't see our patients only by their sexual orientation and by the gender identity, but also as other identities that they may have and how they multiply negatively to affect their outcomes. And what happens with the doctor's bias when you have multiple identity? Well, the bias multiply. I use myself as an example so I don't get in trouble. I'm often seen as unintelligent, spicy, or submissive because I'm a Latino woman, right? So those two identities interact. So when you see your patients that are part of the sexual and gender minorities, remember that they're more than that. And they may have any other issues like socioeconomic challenges, which are very common because many members of sexual and gender minorities couldn't purchase property or couldn't live in certain neighborhoods for a long time in the United States. So most members of the LGBT community will have report a negative experience with providers. And you can see this in this study in which the healthcare provider didn't believe that you were telling the truth. 16% versus 8%. That is twice as much. Healthcare provider assumes something about you without asking. 21% versus 11%. And the healthcare provider dismiss your concerns. 29% over 16%. If that's the experience of your neighbors, of your friends, that also identify like you, will you go to the doctor? No, because I'm going to be excluded. I'm not going to be heard of. So this is what we need to support our patients. Many patients, particularly trans people, are excluded for early detection. These include cervical cancer screening, breast cancer screening, colorectal screening, and lung cancer screening, particularly lung cancer screening. Only 3% to 6% of members of sexual and gender minorities that would qualify for lung cancer screening are getting lung cancer screening. And lung cancer is still the #1 killer of cancer in the US and majority of industrialized countries. So we need to make sure that they get early detection, early detection studies, screening. But I want to share with you that the discrimination that this population face due to our own bias goes as far as the moment of death. I had a patient that self-identified as a lesbian. She had a long relationship with her wife. And at the moment of death, I was not available. I was out of town. Glad I arrived the day I arrived. They will not hear her wife as the proxy because it was a same-sex couple. But legally, they were married. It was legal in that state. So the bias of these providers completely excluded the wife of this patient that's dying based on their unconscious bias about same-sex marriages. So how can we improve? I use and recommend the principles of cultural humility for all doctors, healthcare providers, caregivers, family members. This is assures that you practice these principles every time you interact with a member of a sexual or gender minority. Lifelong commitment to learning and clinical self-reflection. What this means is you don't assume you're instead of assuming, is this your brother? When in fact, maybe their partner? Can you please let me know who's here with you today? So commitment to learning and to improvement. 2, the desire to fix power imbalance, particularly between the physician and the doctor. Develop that relation of trust that regardless of the sexual or gender identity, you are the doctor, you are there for them. And if any of these patients face any discrimination or isolation, you will take action to make sure that this power imbalance is fixed. And to make people accountable, people and institutions, because it's very important that we remain respectful. Something that I'm really seeing is the human rights movement are giving hospitals and places these leader badges that kind of helps members of sexual gender minorities know which places may be more welcoming. And we're also introducing now how to work, understand, and appreciate patients that self-identify as a sexual gender minority during medical school training. So the training and the understanding starts early. This is my last slide. So why inclusive care matters? First, it facilitates, affirms, and a welcome environment for everyone, regardless of their sexual orientation, gender identity, preferences, cultural background, racial background. Also, using the principles of cultural humility and providing equal care help providers address healthcare disparities that we just discussed, and also decrease the risk for specific factors that affect patients that are members of the LGBTQ community. And finally, enable for precision care, for personal care to each patient needs. A transsexual man, we have very different needs than a lesbian woman or a cis man. So personalized care to our patients' needs. That's what inclusive care matters. Thank you for your time. But the summary of this is that your unconscious bias can affect how you care for these patients. Use the principles of cultural humility to improve that, and assure that every day we're learning. But it is our duty that sexual and gender minorities feel welcome in each cancer clinic around the world. My name is Dr. Flores, and it was my pleasure to be with you.